So in our last video, we discussed the pathophysiology of insulin deficiency and resistance, and in this video, we're going to apply this knowledge to better understand diabetes mellitus type 1 and type 2 for step 1. So diving in, what I want you guys to know about type 1 diabetes is the pathophysiology is going to revolve around these antibodies to anti-glutamic acid decarboxylase. And I think this is an important distinction to make because a lot of times people just remember, oh, well, it's some sort of autoimmune process that destroys the pancreatic beta cells. Remember, the pancreatic beta cells are the ones responsible for making insulin. And while the pancreatic beta cells are certainly destroyed through an autoimmune process in diabetes type 1, it's actually antibodies to anti-glutamic acid decarboxylase, which is an enzyme contained within the pancreatic beta cells that stimulates this destruction. Another important point to remember about diabetes type 1 is that it's associated with HLA-DR3 and DR4 serotypes. This comes up very frequently on step 1. It's just important to remember this high yield association because they might ask you a question giving you all these different serotypes and saying, okay, well, if your patient had HLA-DR3 or DR4, what disease process would they be most at risk for? And the answer would be type 1 diabetes. Type 1 diabetes is also associated with other autoimmune processes. I always remember this because type 1 diabetes is the one that has an autoimmune component in its own pathophysiology. So it makes sense that it's also associated with other autoimmune conditions like celiac disease, primary adrenal insufficiency, or Addison's disease, as we talked about in this chapter, or Hashimoto's thyroiditis. And then finally, complications of type 1 diabetes. It's important to remember that DKA is associated with type 1 diabetes. It is not associated with type 2 diabetes, so you really shouldn't be seeing a question about DKA referring to type 2 diabetes on STEP. It should only be type 1. Additionally, complications shared between the two, retinopathy, cataracts, neuropathy, these can be seen in type 1 or type 2 diabetes. The presentation for type 1 diabetes often occurs in childhood, and this is going to be very different from type 2 diabetes. The peaks of when this presents are between 4 and 7 years old and between 10 and 14 years old. The presentation might include polydipsia, polyuria, so it might be a kid that's just drinking a ton of water and mom and dad can't figure out why, or a kid that starts wetting the bed again after they haven't for a really long time, or a kid that's going to the bathroom overnight to urinate. These are all signs that could make you suspicious for diabetes type 1 on STEP. And then weight loss as well can be a symptom of diabetes type 1 in these kids. And then I included DKA here under your presentation because it's not actually that uncommon for the first presentation of diabetes type 1 to be a kid that is now in the hospital with DKA, because as we'll talk about later, diabetes type 1 patients that have this are incredibly reliant on insulin. The problem is their body is not making insulin because these antibodies to anti-glutamic acid decarboxylase have destroyed their pancreatic beta cells, and because they're not producing endogenous insulin, they have nothing to mediate the glucose in their body. That is going to lead to the increased ketogenesis that we talked about in our pathophysiology video, leading to this anion gap metabolic acidosis. And if these patients are completely unaware that they have diabetes, they don't know, they're not replacing their insulin, it's pretty easy for them to get into DKA and have that be the first time that they are presenting and diagnosed with type 1 diabetes. Additionally, retinopathy, cataracts, neuropathy, coronary artery disease, limb loss, and infections, all these complications of diabetes type 1 can all show up in the presentation, but these are usually much, much later. These are usually after someone has lived with diabetes type 1 for a number of years and is well into adulthood. Finally, diagnostics for type 1 diabetes. So as we already talked about, type 1 diabetes is when your body is not making insulin because of this destruction of the pancreatic beta cells. This is going to lead to decreased insulin levels in your body as well as decreased C-peptide. Remember that C-peptide is secreted when you are making endogenous insulin, so it'll be low even if you are replacing your insulin as a type 1 diabetic because this insulin is not produced endogenously, it is exogenous. Additionally, hemoglobin A1C, which is kind of a proxy measurement for how tight your glucose control has been over the past 3 months, that is going to be above 6.5% as diagnostic of diabetes. Other measures, fasting plasma glucose will likely be above 126, and your 2-hour glucose tolerance test, so when we feed you a loading dose of glucose, we have you drink basically some sugar water, we wait for 2 hours, and then we test your blood glucose, that should be over 200. So that's type 1 diabetes. But how does that differ from type 2 diabetes? Well, whereas type 1 diabetes was more of a genetic condition characterized by your body's destruction of beta cells and the inability to make insulin, in diabetes type 2, you actually have insulin around, you're just resistant to it. So This insulin resistance over time is going to lead to your pancreatic beta cells making more and more insulin because there's not that negative feedback to stop making the insulin. And as these pancreatic beta cells work harder and harder over time to keep up with the resistance to insulin, eventually they can fail, but that's not the primary cause of type 2 diabetes. The primary cause is that your body is resisting the insulin. So insulin is going to these receptors saying, hey, I'm here, and your body's not listening. It's not that you don't have insulin around. Complications of type 2 diabetes. The one I want you to associate with type 2 diabetes is hyperglycemic hyperosmolar syndrome. So whereas with type 1 diabetes, I talked about DKA, I want you to remember that DKA is associated with type 1 and HHS, or hyperglycemic hyperosmolar syndrome, is associated with type 2. And HHS is characterized by severe dehydration, but we'll talk about that more in the HHS and DKA videos respectively. The presentation for type 2 diabetes, where for type 1 it was in children, is actually going to be in adulthood for type 2. So that's a pretty good way to distinguish between the two. If this is a patient who is for the first time developing diabetes at 40, 50, 60, it's most likely type 2 and not type 1. Additionally, family history plays a larger role in type 2 diabetes. You may also see polydipsia and polyuria in type 2 diabetes, as you saw in type 1. And then I think it's important to remember that type 2 diabetes, as opposed to type 1, is more associated with obesity and metabolic syndrome. So metabolic syndrome is this constellation of risk factors: obesity, high blood pressure, low levels of HDL cholesterol, and insulin resistance that put you at greater risk for multiple things, including type 2 diabetes, also stroke and heart disease. Complications of type 2 diabetes are very similar to type 1: retinopathy, cataracts, neuropathy, coronary artery disease, limb loss, and infections. And we'll go into all of these in more detail when we discuss the diabetic complications video. The diagnostics for diabetes type 2, I think it's important to note that your insulin levels may be variable. If you're an early type 2 diabetes patient, you may have really high levels of insulin because your body is still able to keep up and say, hey, there's no response to insulin at these receptors, I'm going to keep making more and more of it. But as your beta cells work really hard to produce this level of insulin for years and years and years, they may eventually tire out, and then you will have the pancreatic beta cell failure and then have low levels of insulin. So that's why I put variable levels of insulin, because it depends kind of where you are in this disease trajectory. However, your hemoglobin A1C should always be above 6.5. This is diagnostic of diabetes type 1 or type 2. Your fasting plasma glucose, again, greater than 126, and your 2-hour glucose tolerance test greater than 200. And I think here it's also important to note that there are different markers that mean that you're not quite diabetic yet, but you have pre-diabetes, so we're watching you. And pre-diabetes really only pertains to type 2 diabetes. So if you have a hemoglobin A1C of 5.7 to 6.4, it's not quite at the 6.5 mark, but we will say you're pre-diabetic. So you really need to start focusing on some lifestyle factors to ward off developing type 2 diabetes. Additionally, fasting plasma glucose of 100 to 125, that's also that pre-diabetic range, and the 2-hour glucose tolerance test of 140 to 199. I know that was a lot of information. Let's quickly recap some top points that I want you guys to remember for step 1. Type 1 diabetes presents in childhood. It is associated with this HLA DR3 and DR4 serotype. It is an autoimmune process, and it is the one that is going to be associated with DKA. In contrast, type 2 diabetes is going to present in adulthood. It is not an autoimmune process. It's more controlled by these lifestyle factors that can also contribute to metabolic syndrome. And instead of DKA, type 2 diabetes is associated with HHS. Finally, remembering this golden number that greater than 6.5% hemoglobin A1C is diagnostic of diabetes, as well as having a 2-hour glucose tolerance test over 200 could be important numbers for you to be aware of on step 1. But how do they ask you about this in a board style question? Well, one thing they might ask you is, a 34-year-old woman presents to her primary care physician for her annual checkup. Medical history is notable for type 1 diabetes, diagnosed when she was 7 years old, and eczema. She states that she has been having more frequent bowel movements associated with abdominal pain. She also reports an itchy, blistering rash over the knees, elbows, and buttocks. What is the most likely cause of this patient's presentation? Okay, so this patient has type 1 diabetes. She presented when she was 7 years old, which is right in one of the peaks effects of when type 1 diabetes presents. And now she's presenting for more frequent bowel movements as well as this itchy blistering rash over the knees, elbows, and buttocks. She does have a history of eczema, but eczema is not a blistering rash and it usually doesn't present over the buttocks. What that sounds like more to me is a rash associated with celiac disease, which is another disease that can be associated with type 1 diabetes. Celiac disease can cause frequent, loose, greasy, foul-smelling bowel movements, as well as the type of rash that she is describing, which sounds like dermatitis herpetiformis, which can be found on the buttocks, knees, elbows, and really is this blistering rash that kind of looks like a herpes rash, but is associated with celiac disease. So celiac disease would be my answer. I hope this video was helpful and you feel more confident answering questions about type 1 and type 2 diabetes on STEP, and I'll see you next time.